a myocardial infarction. And according to the guidelines, ECG should be done within 10 minutes. Done within 10 minutes of patient arrival in the emergency or in the hospital. So what we should be looking at the ECG. So the most important thing that we will be looking is the ST segment. ST segment is the most important portion of the ECG that we should look for. So the criteria for a significant ST change in the ECG, they are, so we will look for the ST elevation. ST elevation. So ST elevation significance is and how it is assessed. So ST elevation of more than 1 mm in more than equal to 2 contiguous ECG. That means कि those leads which represent a similar wall is the significance. Like if two lead is there, lead 2, then 3 and AVF are contiguous leads because they represent the inferior wall. They represent the inferior wall. So more than 1 mm in more than equal to 2 contiguous ECG leads, and where it is assessed at J point. J point is the junction of QRS with ST segment, with one important exception, except lead V2, V3. Because normally in V2 and V3 there is a slight physiological elevation also. The J point is physiologically elevated. So what is the criteria in V2 and V3 leads? So the criteria in V2 or V3 lead is the ST elevation of more than ST elevation more than equal to 1.5 in females, and ST elevation of more than 2.5 means less than 40 years of age. So these are the very precise criteria for the significant ST elevation, and more than 2 in males more than 40 years of age. More than 40 years of age. So in physiological elevated leads, we should take the threshold slightly on a higher side. Now there might be a question or a viva question is, what about the presence of left bundle branch block? What will be the significant ST elevation if left bundle branch block is present? So if left bundle branch block is present, the criteria for ST elevation are slightly different there. So the criteria are in left bundle branch block pattern. So just to give you idea, say left bundle branch block in lead V5, say this is a left bundle branch block QRS complex. So normally there is a ST depression normally because of the repolarization defect. So this is a non-ischemic left bundle branch block, means a normal left bundle branch block. This is a normal finding. So what about the ST changes? So ST changes will be ST elevation of more than equal to 1 mm and concordant QRS. Concordant QRS. What does this mean? Concordance QRS. So this means that the ST elevation is there and the QRS are positive. So like this is left bundle branch block and ST elevation is there. Instead of depression, there is a ST elevation. Suppose this is a baseline. So ST is elevated in a concordant QRS. Concordant means positive QRS and ST segment is elevated there. The second criteria along with the left bundle branch block is ST elevation more than 5 discordant QRS. Discordant QRS. Discordant QRS means ki QRS is negative. ST segment is elevated and QRS is negative. Both are going in a opposite direction. Discordant means they are going in opposite direction. For example, there can be some leads where this is the negative QRS complex and this should be the ST elevation. 5 mm ST elevation, more than 5 mm ST elevation should be there with a discordant QRS complex. While ST segment depression, so that will be a non-escalation MI, of course. So ST depression more than 1 mm in leads V1 to V3. V1 to V3 ST segment depression in these particular leads. So these are the important criteria for a case of a left bundle branch block positive with ST elevation or ST changes. Now coming to, so these are the criteria for the myocardial infarction in terms of the ST elevation. Now the second important question which you will be getting or assessing in your emergency is the localization of site of MI. Localization of the site of the MI and the artery which is involved there. Artery which is involved there. So to have a brief idea about the coronary artery, so here you can see this is the blood supply of the heart. We have a right coronary artery and right coronary artery divide to give a marginal branch to right ventricle here. So here is a right ventricle. So this is a marginal, right marginal RM, right marginal artery. And this right coronary artery then go below and this supplies the inferior wall. This is a posterior descending artery, and this is inferior wall. Inferior wall is supplied by the branches via posterior descending artery, and on the left side this is a left main coronary artery. So this is a left main coronary. It divides into circumflex. Circumflex supplies the high lateral, superior lateral wall of the heart, as well as it goes behind and it supplies the posterior wall. The dotted areas are the branch of the circumflex which is going posteriorly, and anteriorly it continues as a anterior descending artery and it supplies the anterior wall and perforator branches to the septum, anterior septum. So this is a broad idea about the blood supply of the heart. And if we look at the this is a suppose a vertical plane of the heart. So this part is represented by lead 1 and AVL. 1 and AVL, they represent the high lateral wall of the heart, while the inferior wall is supplied by 2-3 AVF, is represented by 2-3 AVF. Now if we take a cut section cut section of the heart at this level where we get four major arteries like this. If we take a cut section at this level, so we will get to see a three-dimensional view of the heart, and where the arterial supply is there, and the leads, ECG leads. So let's see here. So let's see here, localization of the myocardial infarction. So if I will make a cross section of the heart, this is the septum. Septum is oblique. Septum. This is right ventricle, and this is left ventricle, like this. So this is a posterior side and this is a anterior side. And if we will look at the ECG lead placements here, so the ECG leads are V1 is here, V2 is here, V3, V4, V5. So these are the chest leads which are present here, and the arteries. This artery supply the right ventricle, right marginal. Here is posterior descending artery. Here is a left circumflex CX, and here is LAD. LAD. So these are the we can identify the different branches of the arteries, different branches of the arteries like this. So if the site is, if we'll make a table of this, if this is a anterior septum, this is the anterior septum which has got infarction. So the site, artery, and lead, ECG lead. The site, artery, and the ECG lead here. Number one is anterior septum. Artery, LAD, perforator branches or septal branches of the left anterior descending artery here. The lead best will be V2, also V1. So the main lead is V2 along with V1. This is very near here. While anterior wall of the left ventricle, whenever we are seeing a anterior wall, we are assuming it to be a left ventricle wall here. So anterior wall supplied by LAD, left anterior descending, and it is represented by mainly V3, V4, but also V2 also. So V3, V4 as well as V2. V2 can also represent here. While left circumflex supply the lateral wall. So if we go to the lateral wall, it is left circumflex, and it is V5, V6 as well as one end AVL. And AVL slightly superior superior wall. Now a left circumflex also supply the posterior wall. So how to know that it is a posterior wall MI? Left circumflex also supply the posterior wall. So what we ask the technician to place three more leads if we are suspecting a posterior wall MI, V7, V8 and V9. These are extended chest. These are extended chest leads. But when should we suspect that it can be a posterior wall MI? When we are seeing ST depression in V1 to V4. V1 to V4 are opposite to posterior wall. So they will produce a mirror image change or a reciprocal change of the ST depression. So V1 to V4 in any ECG you are getting a depression, always ask the technician for V7 to V9 ECG leads. They will show elevation if it is a posterior wall MI. So for posterior wall MI, posterior flex in most of the cases, so it will be V7 to V9 or reciprocal ST V1 to V4. Now, what about the right ventricle MI? RVMI. It is supplied by a right marginal, right coronary artery. So, to represent the right ventricle MI, we remove the left-sided leads and place them on the right side. So, on the right side, the V2 will become RV1. V1 will become RV2, then RV3, RV4, RV5, RV6, same intercostal space but on the right side. So the lead which is nearest to the right ventricle MI, right ventricle wall is RV4, though the changes can be seen in a right-sided V5 or right-sided V6 also, but the most sensitive are RV4, 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 but can be seen in RV5, RV6 also. So this is how to localize the wall of the myocardial infarction and with their arterial supply, So let's do the practice of some of these ECG. So now it is your turn to identify which wall of myocardial infarction you are dealing with. And of course, I have now written the inferior wall. So inferior wall MI, PDA, 2 AVF, 2 3 AVF. Inferior wall myocardial infarction. So now let's identify which wall of MI you are dealing with. So this is just a revision of what we have done. All right. So look at this ECG and identify which wall of the myocardial infarction we are dealing with. Yes, your answers. How to suspect a right ventricle MI? Right ventricle MI will be suspected as we have done in the clinical features of JVP. If we are getting a JVP sign like a small sign, like a raised JVP or a CV wave, so this way we will suspect it is a right ventricle MI. Also, right ventricle MI will be suspected when the patient is in shock but the lungs are clear, there is no congestion in the lungs, no craps, but patient is in shock. So it is a RVMI. And along with that, if inferior wall is MI is seen in standard leads, then it will be most likely associated with the right wall MI. So yes, which wall is this? This is a inferior wall MI because you can see lead to 3 and AVF, they show the ST elevation. Yes, it is a ST elevation. And what about the 1 and AVL? So in 1 and AVL, you see these are the reciprocal ST depression in 1 and AVL. So make it a point, reciprocal sites are 2 3 AVF versus 1 and AVL. These are the sites there. Now the next one, yes, it is a posterior descending artery. Okay, let me see who can identify this ECG wall accurately. Yes, your answers. Yes, so Ravikant has given the answer posterior wall MI first. Yes, this is a case of a posterior wall MI. Reason being, when we were looking for the V1, V2, and V3, we were getting a ST depression. We were getting a ST depression. Yes. We should suspect that it could be a reciprocal change of posterior wall MI. And when we did the V8, look at this lead. This is a V8 lead. There is ST elevation, and also if you can look here V9, so ST elevation, so at least V8 and V9 they are showing the ST elevation, so it will be a posterior wall MI. Yes, it is a posterior wall MI. Also, you can see in lead 1 and AVL. In lead 1 and AVL, there is also ST elevation. There is also ST elevation. So this more goes in favor of a high lateral and posterior wall MI. High lateral and posterior wall MI, which are supplied by the left circumflex. Left circumflex. So yes, this is a posterior wall MI. Now, what about this? Look here. Yes, Dr. Ravikant has given inferior wall MI. Yes, true. But what else? Yes, you are right. In 2, 3 AVF, there is ST elevation and with reciprocal changes in 1 and AVL. So no doubt it is a inferior wall MI also, but there are other changes as well. So inferior and lateral wall. So inferior and lateral wall MI combination is slightly uncommon. You can think of the blood supply and identify whether inferior and lateral wall both can be affected or it will be a coincident, but that coincident will be less. So always justify the answer with a common artery. Common artery. So inferior wall is supplied by the right coronary artery, and here there the lateral wall is not affected. It is, look carefully, V1R, V2R, V3R, V4R. So this is a right sided lead. The R word is right sided. Right sided. So this is not imprinted on the ECG by the computer, because only we and technician know कि mechanically we have put the leads on the right side. So we manually write R on the ECG. So here they have written a manual word R after these leads. So this is a right side V4 and there is a ST elevation. So this is a combination of right ventricle MI. So always look for that R word if inferior wall MI is present. If inferior wall MI is present, look carefully whether they have manually written the right sided lead or not, because the arterial supply is same. So it is inferior wall with right ventricle wall MI. Now, coming to this one, Yes, this one. Yes, this is anterior wall MI, and any other wall which is affected here, any other wall, look carefully. So V2, V3, V4 gross ST elevation, and look, V5 also shows ST elevation, and V6, yes, there is a ST elevation, even 1 mm of ST elevation we can consider as significance, as well as go to lead 1 and AVL. So 1 also shows ST elevation and lead AVL also shows ST elevation. So it means it is a anterior wall as well as a lateral wall. So it is this suggests it is a lateral wall which was affected and anterior wall here. So it is a totally anterolateral wall. Am I anterolateral wall? Yes. Anterolateral means ki most likely this left main coronary was blocked. It was blocked, and that has lead to a extensive MI, anterior wall as well as the lateral wall. And remember, when left main coronary is blocked, the treatment is bypass, not the PCI, not the PCI. Yes, so it is a both anterolateral MI. So both the walls are affected here. Most likely it is a left main coronary artery block. So these are few ECG of the myocardial infarction, which you should be practicing more and more uh, in your emergency. All right. So now come to the other test that we do for a case of myocardial infarction. This was a very important test, that is a ECG. Now